Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and
Well,
gentlemen. Thank you for this amazing opportunity. My name is Aditya Virabwana, and I am currently working as an otorhinolaryngologist, head and neck surgery at the Faculty of Medicine Hantula University Surabaya and at SPAL the Perambalan Surabaya. And this time I will present our research conducted in Dr. Sutomo General Hospital in Surabaya in last 2020, entitled Pepsin A as a biomarker in chronic rhinosinusitis and chronic rhinosinusitis patient caused by laryngopharyngeal reflux. So, see, first of all, rhinosinusitis creates a significant health problem in general population, especially in Indonesia. Since March 2020, as we know, patients with recurrent rhinorrhea accompanied by the anosmia and hyposmia are currently suspected of being a symptom of a COVID-19 infection. This problem is unfortunate and unavoidable in this pandemic situation, considering these are typical symptoms of rhinosinusitis. Various etiologies other than infection, namely anatomic abnormalities, allergies, pollutants, or we can say smoking, and laryngopharyngeal reflux or LPR, can cause CRS. There is a possible double increase in the risk of developing chronic rhinosinusitis with the laryngopharyngeal reflex. And still, LPR is currently considered as one of the causes of CRS. Pepsin itself, which is only produced by gastric parietal cells, is believed to be one of the causes of chronic rhinosinusitis. And we know that human pepsin A in the nasal cavity can be a really good biomarker for LPR, and it could be detected by using lateral flow device. The study aims to determine the correlation between CRS and LPR based on the presence of human pepsin A in the nasal cavity. So the study was a prospective cross-sectional study with consecutive patients who came at the ENT outpatient unit and fulfilling the research criteria. The inclusion criteria were over 80 years old patients who had a nasal discharge and or nasal obstruction for more than 12 weeks. An NSI score is more than 13. The exclusion criteria were patients with suspected chronic rhinosinusitis with nasal polyps, tumor, or severe anatomical abnormalities as evidenced by nasal endoscopy. Include use an anti-reflux medication in less than 48 hours, smoking and consuming daily carbonated drinks or alcohol in less than an hour. All data was analyzed using the chi-square test with significance level less than 0.05. Statistical test analyzing using IBM SPSS, and this study already fulfilled the ethical clearance. And fun fact, in this study we use a PEP test. It's something not similar for every hospital have. We use a PEP test from RD Biomed Ltd, Cottingham, UK. This is a rapid enzyme link immunoassay for detection of pepsin. This is a very rapid test and non-invasive and based on the lateral flow device technology. This test could detect pepsin until 60 nanogram, and to best our knowledge, PEP test has been used with nasal secretion in some previous studies. The diagnostic of CRS follows the FS 2020 criteria, when the LPR diagnostic is enforced according to the RSI and RFS questionnaire. Patients who met the inclusion criteria were sampled for nasal irrigation using an aqueous distillate as much as 0.5 milliliter from each site with a modified nasal spray. If the examination cannot be carried out on the same day, the specimen must be stored in a refrigerator at temperature of 5 degrees Celsius for a maximum of 7 days. As we can see in this PowerPoint, we can see this is T is we can see a test and C is control. And we got two ribbon like this. This is we call positive pepsin. This is what should we do for the test. Uh, so for the result, a total of 35 patients has contributed to this study, consisting of 25 CRS patients and 10 patients with non-CRS. The CRS group consisted of 10 males and 15 females. There were four symptoms experienced by all patients based on the RSI questionnaire, which you can see on the graphic, heartburn, chest pain indication, or stomach acid coming up, sensation of something sticky to your throat or a lump in your throat, excess throat mucus or postnasal drip and clearing your throat. And the highest in reflux finding score in chronic rhinosinusitis cases were posterior commissural hypertrophy in 20 patients. The pepsin A finding in the chronic rhinosinusitis group was 83.3%, which is compared to 16.7%. And the study facial correlation test was used to replace the chi-square method because one of the group cells did not meet the minimum sample criteria. So, based on the result, it was found that the most gender groups in chronic rhinosinusitis were female. The reason for this result remains unclear until now. But some factors that are considered are anatomical variations, smoking history, and hormonal influences. As we know, estrogen play a dominant factor in direct role in stimulating parietal cells and the peptic gland without intervention from the nervous system. From the age distribution, we found that the largest was the 18 to 40 years age of group, as many as 23 patients, and this means that the working age population shows more symptoms due to the exposure to high-risk factor of chronic rhinosinusitis. From the reflux symptom index or RSI, excess throat mucus or postnasal drip is one of the symptoms of LPR that is often found in CRS patients. This is in accordance with previous research. Back to our main variable, which is a human pepsin A in the nasal cavity, as we know that pepsin is a type of proteolytic digestive enzyme originates from the pepsinogen secreted from gastric sheath cells. This is mean that the finding of pepsin in upper airway digestive tract should be a diagnostic marker of direct reflux exposure. But because of nasal mucosa is different from the esophageal mucosa, it has a limited self-protection against direct reflux. There are two distinct pathophysiological mechanisms. The first one is through the direct reflux to the extraesophageal mucosa. Uh, the mechanism of the direct exposure of refluxia results in local inflammation. This process will also go through the esophageal nasal reflex, so we can say esophageal reflex, and it creates inflammation along the upper airways. And of course, affected goblet cells and ciliary dysfunction lead to the excessive production and accumulation of mucus secretion. This study where we also found a high number of positive tests in patients. Uh, this result also support the concept of postprandial reflux, which is food intake will increase pepsin concentration during the digestion process. Most individuals reflux a small amount of gastric contents after meals, even without having symptoms. We should discuss about activation and reactivation pepsin first. So the first mechanism is acidic reflux, which is pepsin will be active in acid condition with pH about 2 or 3. So the acidity reflux in the extraesophageal tissue varies up to pH about 6, but the acidity in the mucosal area of the upper respiratory tract is about 7.4. This condition causes pepsin in the extraesophageal mucosa to become inactive, and then refluxant containing pepsin has a mucosal damaging effect only at pH 4 to 6. Because the pepsin is in an active condition, naturally there will be a second mechanism. It may occur due to endocytosis of pepsin into intracellular tissue that have a lower pH, such as a Golgi apparatus, which has the pH 5.5. or mitochondria. Inactive pepsin becomes reactive again and cellular damage will be detected within 12 hours appear along with the presence of biomarkers of oxidative stress, free radicals and histoproteins. In previous studies, it was found that cells will be damaged even once exposed to pepsin, but will survive and remain active within another 12 hours. And they also found an elongation of mitochondria in non-acidic environment. Uh, Pepsin A direct exposure in a non-acidic environment will induce some cytokines and pro-inflammatory receptor. It will trigger the proliferation and transformation of the epithelium of the exposed tissue depending on the level and duration of the reflux. Mitochondrial damage could reduce the ATP production, affecting frequency and synchrony of ciliary beating, and of course impair the mucociliary transport. This process can be mutually exclusive, and the data in this study found a significant difference in the number of positive peptide results between the CRS and non-CRS group. But the finding of this study did not necessarily make a human pepsin A the only cause of CRS. Interestingly, in previous study by Kettle et al. In 2019, there are significant results when referring to the 2-hour postprandial specimen, but not significantly found in the morning specimen. But in another study by Sotwell G.E. et al. In 2015, pepsin is present in sinus from patients with CRS and is a potential biomarker for extraesophageal reflux in this chronic rhinosinusitis. So, based on this and previous studies, human pepsin A may be responsible for a sinonasal tissue injury in chronic rhinosinusitis. And clinicians should consider that LPR treatment for chronic rhinosinusitis, a patient with reflux symptoms, of course. Further research would be better by using a quantitative spectrophotometry to show amount of the pepsin precisely in each specimen and accompanied by pre- and postprandial in 3 different sampling times with a larger number of patients. Conclusion: there is a correlation between a CRS and LPR based on the nasal pepsin A examination, and this can be demonstrated by a significant positive pepsin A examination in the CRS group compared to non-CRS. This study shows that LPR can be one of the factors causing the CRS, and laryngopharyngeal reflux disease can be used to prove, and the LFD, lateral flow device, can be used to prove the presence of pepsin A in the nasal cavity. Acknowledgement: we acknowledge that the contribution of the individual participant who took part of this study. Thank you very much.